already tired. I get it. And I understand that if you start looking at this material, I've heard some of you chit-chattering about things. If you start looking at this material, it's a little overwhelming when you start looking at it, okay? Hopefully by the time I get done, it will make a little bit more sense to where you can put things in categories to make it a little bit easier to understand. I also made you an outline. You're welcome to write on this. This is yours to keep. You can draw on it, write on it, whatever you like to do. You don't like it, you want to throw it in the trash, that's on you too. Whatever you like to do. But I did make it today because I thought, you guys have had a test, you're welcome. Usually when I teach this in 211, it's not after a test, so you had some time to prepare. However, today, you had a test. You don't have any time to prepare. So I want to make sure that we really hit the highlights. All right, this kind of goes along with the prep work. You don't have to do it. This is just to kind of follow along with in lecture today. Did everybody get one? Fantastic. So you should be able to follow this along as we go talking about stuff in lecture today. You're welcome to write down anything that I say. I will tell you that I'm not a very vague person, meaning I'm not going to go open a book and pull out the most random thing and test you on it. Okay? You're welcome. That's not how I test. Everything that you need to know about these disease processes and fluid and electrolytes and how it relates to it, I will tell you. You will usually hear it come out of my mouth, okay? I did put a PowerPoint up. I'm not a big PowerPoint person. I'm just going to shut doors if y'all want to do it. I did put a PowerPoint up. If the thing, PowerPoint's the way you like to look at things, you're welcome to. I also think it's good to look at your NCLEX review book or your HESI review book. Now, you go searching through those things, you're going to have a really hard time. You're going to have a really hard time finding a lot of information, especially related to Addison's disease, Cushing's, diabetes insipidus, SIADH. You'll find more about the thyroid crises and more about the diabetic crises than you probably will anything else. I will tell you, I've been a nurse for 20 years. Emergency medicine is my background. So I've had a lot of patient encounters in my 20 years of nursing experience. I have had maybe one patient with SIADH. I've never physically seen diabetes insipidus. I've had one patient with Cushing's and one with Addison's in 20 years. Which amazes me why it's something that we still really talk about and teach about, but we do. I remember back on my nursing boards when I took them, I had a question about Addison's. That's the only question I remember on my nursing boards. That was 20 years ago. But I remember seeing something about Addison's. I have no idea what it asked me. I just remember seeing it and thinking, what the heck is that? I don't even know what this is. Because we didn't learn about it when I was in nursing school. Your endocrine system is comprised of a lot of different glands throughout the body. Now, most of the glands we're going to talk about are up here. We're not going to talk about the ovaries and the testicles. Okay, you already had that in 114 when you did reproduction, so we're not going to do that. Talk about sexual health and all that. We don't need to know about testosterone and estrogen and progesterone. Okay, so that's way out yonder. You don't need to worry about those types of endocrine glands. But with relation to the endocrine system and fluid and electrolytes and how they all work together and how they can affect these types of crises. Now, all these that are listed up here can be considered medical emergencies. If patients have any of these, most oftentimes they wind up in the ICU just because most of them require different types of neuro checks and are usually on different types of medications that really have to be monitored carefully. Okay? Like I said, working in the ER, I've only ever had maybe a handful of patients that had any of these things, have had a lot of DKA. A lot of DKA. You will see that and probably HHS more than you will see any of these other things. Okay? We're also going to be pulling back information that you learned in 113. So if fluid and electrolytes was a difficult concept for you in 113, pull it back out. I already see some faces being made at me. back out, okay? Because you will need to know some of that information to help you with this as well. I promise you I will tell you everything I want you to know. If you have questions, please ask me. I do not know everything. I will tell you that right now. I do not know everything. However, if I can't answer it, then we're going to figure it out together. Okay, there's this lovely thing called Google. You know, we can just type in, hey, what does this mean? AI is amazing. It has a lot of different things in there, and you got to be really careful when you ask AI stuff, though, because I have found a lot of times it is wrong. So you got to be very careful with that. All right, so let's talk about fluid balance in the body. Your body's main responsibility is to maintain homeostasis. We can do that in many different ways. How it relates to your fluid volume, though, is your hypothalamus, which is right here, my little nice little circle area. It's responsible for sending signals down to our pituitary gland, and that pituitary gland releases a hormone or holds on to a hormone, tells our body, hey, you either need to hold on to the urine or you need to let it go. Meaning, we're going to release the hormone specifically related to that is ADH, or your antidiuretic hormone. And we're going to talk about more hormones here in just a minute. But in order for your body to maintain homeostasis, you have to stay within fluid balance, okay? You got too much water on board, what are you? Huh? Hypervolemic. You're diluted. You got too much volume. So too much fluid equals I'm diluted. What about if I have too little fluid? Hypovolemic, or also known as concentrated. I want you to think of it in terms of osmolality as well. So is it diluted or is it concentrated? Too much fluid on board, you're diluted. You have too much solution as opposed to all the solutes that are floating around. When I say solutes that are floating around, what am I talking about? Electrolytes, blood, all the stuff in your body that's floating around. All right? Inside your bloodstream, you have fluid and chunky stuff. That's what I like to think about it. Fluid and chunky stuff. All right? You got too much fluid on board, then you're diluted, you're saturated. You have way more fluid than you do all that other chunky stuff that's allowed in there. You have too little fluid, you're concentrated, meaning you've got more chunky stuff than you do volume. Your fluid balance goes between these different areas. You have your intracellular fluid. Then you also have your extracellular fluid. Your extracellular fluid is comprised of your intravascular fluid and your interstitial fluid. So in order for your body to maintain that balance, you have to have fluid shifting between all of these areas. Now, your body normally should do that on its own. You should maintain normal homeostasis. Everything should be in balance. But every now and then, something breaks. All right? Last night, we were installing a toilet at my house. We inherited a 120-year-old house. God bless us, is all I can say, because it has been insane. Well, we were trying to install what my husband likes to call a big boy toilet. If you've ever seen my husband, he's a big guy, really big guy. He's the one you'll see driving around the gator that's got a mullet and he flies like a bat out of hell. Okay, that's mine, I know. I tell him to slow down all the time, but it never fails. He's like a little kid when he gets on that gator. But anyway, we were installing our big boy toilet last night, and the line that went from the valve to the toilet literally broke in my hand. And I have water shooting everywhere. And I was like, what am I supposed to do with this? There's literally water going everywhere. There's no stopping it. Turn the pump off at the breaker box, didn't work. Had to go outside and turn the pump off at the well. The whole time he's running around trying to turn the pump off, I'm over here just like with towels, hands, everything. My son walks in, who's 17 and a smart butt. He's like, really? You're being sprayed with toilet water? I said, well, as a matter of fact, it's actually clean water. It is not toilet water, just so we're clear. Eventually it stopped. He finally got it turned off, and we had to replace it, get a whole new valve, everything. We wound up going to Home Depot and getting home and fixing the toilet about 10 o'clock last night. It was a lot of fun. Same thing happens in your body. Things break, and you got to figure out why they broke, how to fix it, and what you need to do in the meantime to maintain that homeostasis, okay? So when we're thinking about people who are off balance, either they have too much fluid or they have not enough fluid, When we're assessing fluid volume status, how do we assess that? What are some things that we're looking for?
Edema.
Okay, I like it, edema. So we're gonna assess for edema. Where can we assess for edema at?
The extremities.
Okay, our extremities. Where else?
Listen to the lung fields.
What do you hear?
Crackles.
Okay, so listen to your lung sounds. I like it. You can also see if they've got any kind of truncal edema. Any kind of edema in this area. You know, do they have generalized edema? Do they have dependent edema? Do they have truncal edema? Ascites? All those things can be a sign of fluid volume issues. Lung sounds, are they clear or are they crackly? Crackles tell me what? Crackles tell me I got fluids in my lungs. I ain't supposed to have crackles, am I? Those are what we call adventitious lung sounds. We don't want none of those. No adventitious lung sounds allowed. We want clear, good lung sounds. Crackles are going to tell me that I've got fluid where it doesn't belong. If I have fluid in there, then I don't have good gas exchange. Y'all just learned about gas exchange, right?
Yes.
Or you relearned about it, I guess, because you did the compensation part of it. I know that probably drove some of y'all crazy, didn't it?
Yes.
How many of y'all do that tic-tac-toe mess? None of you. If you do, you're not going to raise your hand now that I said mess, sorry. Tic-tac-toe. I had a student try to teach me how to do tic-tac-toe one time in the middle of a whole crowd, and I'm sitting here teaching about complicated ABGs, and I'm like, I have no idea what you're talking about. It was very confusing for me. I could not do no tic-tac-toe mess. I have to do old school Rome. Who does tic-tac-toe? Somebody does. Love you, Zach. Yeah, it was very difficult for me. Dr. Fuller tried to teach me how to do it one time too, and I was like, I can't. I literally cannot. Like, my brain cannot function that way. It's like with math. I used to do ratio and proportion, and I had a whole class that only knew dimensional analysis, and I was like, I don't know what that is. Like, I took chemistry a real long time ago. And they set me down and taught me dimensional analysis, and now I can't do ratio and proportion anymore. It literally, like, kicked it out of my brain, and I didn't know that was even possible. But yeah, kicked it out of my brain. Like, nope, can't do that. But nonetheless, whatever works for you, right? So lung sounds, edema. How else can we assess fluid volume status? Weight gain, daily weights, I like it. Daily weights, I have to write and then talk because I can't do two things at one time. Daily weights actually is the number one thing that you can do to assess fluid volume status. That along with your urinary output. Now, is my patient gaining weight? Are they losing weight? Is my patient voiding? Are they not voiding? What's a normal urinary output?
30 milliliters an hour.
About 30 milliliters an hour. That's relatively normal urinary output. Anything less or more, then we got a problem somewhere, right? Daily weights, I really shouldn't gain, 4 pounds in one day. I gained 4 pounds in one day. Either I ate an all-you-can-eat buffet for like 6 hours, or I held on some fluid somewhere, right? All right, what else can we do to assess fluid volume status?
Blood pressure.
Okay, how about we just do vital signs altogether, right? The two main vital signs that you're worried about are going to be your heart rate and your blood pressure. Now, if I'm overfilled or overhydrated, what's my blood pressure going to look like?
High.
High. Why is it going to be high?
Too much going through it.
Pressure on
Too much pressure, too much volume going through, too much pressure on the vessels is going to cause your blood pressure to rise, right? Well, if I'm dehydrated, what's going to happen to my blood pressure?
and drop
It's going to drop. Why?
because the volume inside of it.
Because I ain't got no volume. I ain't got nothing to flush through there. So there's no resistance. There's no extra pressure pushing through a whole bunch of fluid. Now there's barely anything trickling through, so my pressure's going to drop. All right, what about your heart rate? What's your heart rate going to do if you're dehydrated? It's going to increase. Why does it increase?
It increases pressure.
Helps, works as a compensating type thing. Compensatory, I think is what I was trying to say, but I'm cornbread, so I have a hard time saying certain words. Yes, so your heart tries to compensate because I don't have any extra fluid. Well, maybe if I pump faster, I'll get more fluid. That's why your heart rate increases when you're dehydrated. What about when you're overhydrated?
Should be the opposite.
It's awesome.
You would think it should do the
It's still
opposite.
tachycardia.
Or its own thing. It really can be either or. It can be stay normal or it can be tachycardic because you have a lot of excess fluid going on. When you're overhydrated, you're more concerned about your blood pressure. The blood pressure being high. When you're dehydrated, you're worried about hypotension and tachycardia. Okay? So those are your two main vital signs when it comes to assessing fluid volume status. What else?
JVD. JVD.
JVD. Okay. So what does JVD tell me?
If there's too much fluid in the.
Okay, so if I'm oversaturated with fluid or I'm overhydrated, I'm going to have JVD. What if I'm dehydrated?
A bounding pulse? Yeah.
Dehydrated, I'm not going to see JVD. Just like I should in a normal hydrated patient. The only time JVD will play a factor is if you are overhydrated. You will see JVD if you're overhydrated. All right, what else?
Capillary refill.
Capillary refill didn't really do much for fluid volume status.
It's not like-
Skin turgor?
Okay, skin turgor. I'm dehydrated, what's it gonna do?
Stay up on it.
It's gonna tint. If I'm overhydrated, I might have a hard time getting skin turgor depending on where I'm looking for it at. But it kind of goes back along with the heart rate if I'm overhydrated. Really, your skin turgor is not gonna change very much unless you are just extremely full of fluid and then you're not unable to assess skin turgor. Skin turgor primarily is affected with dehydration. We're gonna see elastic or tinting skin, meaning non-elastic skin. All right, what else?
Electrolyte panels, labs.
Okay, we're gonna go down there here in just a minute. Hold that thought for a second, Josh. What else? Thinking about putting your hands on your patient, putting your stethoscope on your patient, you're physically assessing them. If I'm worried about their fluid volume status, whether they're overhydrated or dehydrated. Okay, level of consciousness. I will tell you, level of consciousness can be seen in dehydration as well as overhydration. You can see a change in level of consciousness in both of those, which we're going to see that with some of the electrolytes that we have that are out of whack. Your main electrolyte being sodium. All right, what else? There's one really big one that nobody's mentioned. I'm putting my stethoscope on my patient. What am I listening to?
Murmurs and cardiac sounds.
Okay, heart sounds. Heart sounds is a big one. I should hear a normal S1 and S2, right? Somebody who's dehydrated, they're going to have bounding pulses, they're going to be tachycardic. But someone who's overhydrated,
S3.
they can also have bounding pulses, excuse me, let me go backwards. Dehydration, their heart sounds are going to sound fine. They're going to be tachycardic. They're just going to be fast. And they'll more than likely have thready pulses. I said that backwards, my apologies. So tachycardia, thready pulses when you have dehydration. Overhydration, you're going to have bounding pulses. But you could also hear an S3. Now, S4 is never normal, no matter what you do. S4 is never normal. S3 is heard in patients who are in fluid volume overload. So that's patients who are renal failure patients that are in fluid volume overload, heart patients who have congestive heart failure. You'll also see this sometimes in your pregnant patients when they're in fluid volume overload. So we should hear an S1, S2, but if they're in fluid volume overload, I might also hear an S3. All right, so looking at patients who are dehydrated, all right, dehydrated. Not really gonna have any edema issues, not gonna have any lung sound issues. I might see some decrease in their weight. Definitely will see a decrease in their urinary output. Vital signs, if I'm dehydrated, my blood pressure is gonna be fine, maybe low. It's gonna be low. Your blood pressure is gonna be low. What's your heart rate gonna be? High. JVD, am I gonna see that with dehydration? No. Skin turgor, what am I gonna see? Tinting. Level of consciousness, I might see a change in that if I'm dehydrated. And heart sounds, I really shouldn't see anything. Now, if I'm overhydrated, I'll hear an S3. Overhydrated, I'll be hypertensive. I might be tachycardic, but my heart rate might be the same, might be normal. Primarily, your blood pressure is affected if you're overhydrated. I will have a positive JVD. Skin turgor is really not affected unless it's non-elastic, non-tinting, nothing, because it is so puffy you can't even squeeze it. Level of consciousness, might see some change there. Urinary output, if I'm overhydrated, there's a very good chance my urinary output's gonna go up. My daily weights, what are they gonna do? Go up. Lung sounds, what am I gonna hear? Crackles. And edema can be present in your overhydrated patients. Could have ascites, they could have generalized edema, they could have pitting-dependent edema. You can have orbital edema or facial edema. Now, when we talk about assessing our patient, putting our hands on them, putting our stethoscope on them, these are all the ways that we are assessing fluid volume status, okay? Keep that in your mind for when we start moving down. Now, Josh, let's go back to our labs. What labs do I want to do? What's important when it comes to fluid volume status? What labs do I care about? Okay, electrolytes. So I'm probably going to do a complete metabolic panel. And I'm really going to pay attention to my electrolytes. Now, you should have known already when you did cardiology that the four main important electrolytes are going to be your sodium, your potassium, your magnesium, and your calcium. All right? With fluid volume status, those are very important. However, the most important ones that we're going to see issues with are going to be your sodium and your potassium. Now, if you remember back to fluid electrolytes back a couple semesters ago, I know it's a while. How does sodium and potassium relate to each other?
If one is higher, the other one is like the opposite of it.
Opposites. Usually they're inverse from each other. They try to balance each other out. Remember you have your sodium potassium pump? We try to balance everything out. We're either going to put some out or take some in, one or the other. Okay, so usually they are one's high, one's low, one's low, one's high. Usually they're inverse from each other. But those are your two main electrolytes that we're really going to be concerned with fluid and electrolytes. All right, what other lab work am I concerned with relation to fluid volume status?
H&H.
I like it, H&H. When I'm looking at an H&H, am I paying attention to that hemoglobin? No, I'm really more so looking at that hematocrit. All right? What's the difference in a hemoglobin and a hematocrit?
One is the size.
Siri.
Hey Siri? Man, I thought this was going off in a minute.
One is the size of the red blood cells and one is the amount.
Okay. Hemoglobin is your oxygen carrying capability blood cell, right? Hematocrit is all the other stuff. So think about hemoglobin carries my oxygen. Hematocrit really just tells me what my fluid volume status is. So hemoglobin, yay, because it carries oxygen. I need oxygen all throughout my body. I need hemoglobin. There's usually a 3-to-1 ratio when it comes to hemoglobin and your hematocrit. Hematocrit's all the other chunky stuff in your blood. Okay? Think of it that way. It's all the other stuff that's out there. Your hematocrit's going to tell you whether or not your fluid volume status is balanced or if I'm diluted or concentrated. Okay? So we're going to talk about your labs here in just a minute with relation to dilution and concentration. All right, what other labs would I be concerned with for fluid volume status?
Urine specific gravity.
Okay, urine specific gravity. What does urine specific gravity tell me?
The amount of
Concentration.
solids in the urine.
How concentrated I am, right? If I'm diluted or if I'm concentrated. Meaning my urine, not my body, right? My urine that comes out, is it diluted or is it concentrated? All right, I heard somebody else say something else over here. Your BUN and your creatinine. What does your BUN and creatinine tell me?
If
my kidney function. Remember, there's two excellent ways to assess fluid volume status that are very important. That's your daily weights and urinary output. Okay, I can put them on a scale, but I can also look at my BUN and creatinine and tell how good my kidney function is, while also looking at my urinary output. All right, so I have complete metabolic panel, really paying attention to that sodium and potassium. Looking at my H&H, really paying attention to that hematocrit. I'm looking at my urine-specific gravity to see if I'm concentrated or diluted. Don't start that mess again.
It always does an extra.
I'm gonna get a baseball bat out of that thing in a minute. It messed up my train of thought. All right, another thing that I can look at is serum osmolality. Now, you can actually do a blood test for serum osmolality to tell how concentrated or diluted your patient is. It actually is a really good blood test that they can do to determine hydration status. There is a way to do it. They can draw just a serum osmolality test. They can also take your sodium level times 2 divided by BUN divided by 1.8. It's a whole formula. You don't have to know all that, okay? I don't expect you to know all that. Just know that serum osmolality is another blood test that can be done to determine whether or not your patient is hydrated or dehydrated, okay? Or overhydrated. I was looking at that the other day and I was like, good gosh, I don't even know what the heck that means. Like, it was so many weird numbers. I didn't even know how they calculated that. So when you think of someone who is overhydrated, they are diluted, right? We got too much solution and not enough chunky stuff, right? So if that's the case, what's going to happen to my sodium?
Gonna go down.
It's going to go down, right? Because I've got fluid up here, solutes down here. All right, well, we just said that our sodium and potassium are kind of inverse, right? One fun thing about potassium, where does it like to live? It's intracellular, okay? So usually a normal sodium or a normal potassium level is 3.5 to 5. Normal sodium level is 135 to 145. You see the drastic difference there? That's because usually your sodium likes to hide out in the extracellular spaces, primarily in the intravascular spaces, which is why that blood level is so high versus your potassium that is so low. And remember, they're inverses. So if I have someone who is overhydrated, I'm diluted, I've got more volume, sodium's going to be down here. What do you think might happen to my potassium? It'll go up. Okay? Hematocrit, same thing. I'm diluted. What happens to my hematocrit? It drops. People can look at an H&H and be like, oh my gosh, my patient's anemic, they need blood. When all in reality, they have congestive heart failure and they're not taking their water pill and they're overly hydrated. They don't need a blood transfusion. Instead, we need to get some of that fluid off and maintain that balance. Okay? Urine-specific gravity measures the amount of waste water in the urine, or waste to water in the urine. If it's high, usually it's because your urine is concentrated, meaning there's more waste. If it's low, it means it's diluted. Your BUN and creatinine are your kidney function test. Anybody know what a normal BUN is? 10 to 20. Normal creatinine is?
0.5 to 1.2.
Yeah, or 0.6 to 1.2. 0.5 to 1.2 sounds good too. I think that's what's on y'all's little sheet, if I'm not mistaken. Usually, if these are severely elevated, it can be because of renal function issues, meaning my kidneys aren't working appropriately. However, another twist to that is they can also be elevated if my patient is severely dehydrated. So it might look like they might need to go on dialysis, when in all reality, they just need fluid. It's not going to change that much if they're overly hydrated. You might see it be a little lower, but primarily you're going to see this messing up when you're dehydrated. All right, serum osmolality, same thing. Is it diluted or concentrated? That's all you need to know about that. I don't expect you to know these lab values, by the way, this one, or this one. So your hematocrit, your urine-specific gravity, or your serum osmolality. I do not expect you to know those levels. You should know sodium, potassium, and BUN and creatinine. Okay? Any questions with that? All right, now say my patient is dehydrated. What can I do for them? What can I do as a nurse? What do I do for them? Fluids. I can push fluids. What if I'm overhydrated? What can I do? Diuretics. Maybe fluid restriction along with some diuretics. So let's talk a little bit about fluids and how they relate to the body. Now, you have isotonic fluids. That's going to be like your normal saline and your lactated ringers, right? Normal saline, 0.9% normal saline or lactated ringers. Means there's no fluid shifting. It has the exact same osmolality in that bag of fluids as it does in your bloodstream. Meaning there's no fluid shifting. So that fluid just goes in here and hydrates the intravascular system. There's no fluid shifting at all. No moving around. It's primarily used for acute dehydration. LR, mostly for trauma patients, burn patients, OB patients in labor. The only issue is you have to be very careful with LR if you have a patient who has renal issues. Do we know why? It's the lactate. They cannot metabolize and excrete the lactate. All right, I also have, my purple marker's down here. I also have hypotonic solutions. I think about hypotonic solutions, I think about a hippo. Hippos are fat. They're gonna swell, right? So what is hypotonic solutions gonna do? It's gonna pull fluid from here into here, right? So we're gonna pull fluid from this extracellular area into the intracellular area. That's my hypotonic solution. Because I'm going to cause swelling. I'm going to hydrate those cells. I'm going to pull fluid from this area here into the intracellular area. Think about hypotonic, hippo, fat, we're going to swell the cells. Problem with that is you swell too much, well, you're going to bust your cells. And what likes to live inside the cells? What happens if I bust this cell? What happens to all that potassium? It goes in there. And then that 3.5 to 5 gets a lot higher. And what does that like to do to my heart? Dysrhythmias. We don't want that to happen. And be very careful with your hypotonic solutions. Most oftentimes, your hypotonic solutions are really important in patients who have high sodium levels. So hypotonic solution is good for patients with a high sodium level. Why do you think that is? High sodium levels. Water follows salt, salt follows water. If I pull all the water out, what's going to follow? All that extra salt that's in there that's not supposed to be there. I'm going to pull it out. Which is why your hypotonic solutions are really good for patients who have hypernatremia. They're also really good for patients who have chronic dehydration or long-term dehydration. So someone who's had nausea, vomiting, diarrhea for 4 or 5 days, normal saline just isn't cutting it no more. We'd have to give them some hypotonic solution. But primarily it's used in patients who have hypernatremia. All right, last is hypertonic solutions. Hypertonic solutions do what? What happens when you exercise a lot? You're really hyper, you're really exercising, you get what? Thin. I don't like to exercise, okay? Hypertonic solutions, hyper, fast, active, that's going to thin out the cells. So where are we gonna go? We're gonna move from the good marker. Move intracellular into the insular vascular area. That's your hypertonic solution. That's really helpful in hyponatremia. Now, all this will come together in a minute when we start talking about these exemplars down here, so y'all with me still? Anybody confused? Great. So hypertonic solutions, we're gonna pull fluid from the cells into the vascular area. It's great for patients who have hyponatremia because what do we want in here? We want to increase this, right? And we know that water follows salt, salt follows water, so if I pull some extra water into here, salt's gonna follow and go where it needs to be. So that's a great treatment for someone who has hypernatremia. Hyponatremia. I said hyponatremia. I need you to rewind that, Zach, and fix it and bring it back, okay? It's also great for patients who have edema. Why is it good for edema? Takes it and puts it into the IV area, and then what can we give them? Diuretics, and then where's it gonna go? Out the body. Okay? Now, one very weird IV fluid is D5W. 5% dextrose in water. Now, if you look at the 5, I made you a little chart right here. Okay? All the big numbers are hyper. 0.9% is the middle. Your median, think of it as your 7.4 on your acid-base scale. That's your neutral, okay? And everything that's low, the less than 1, are gonna be your hypotonic solutions, okay? With one really irritating one, like D5W, you see the 5 and you think it should be what? It should be a hypertonic. Now, D10, D5, D3, not D3, D5, D10, D20, in normal saline, all those are hypertonic solutions. But D5W means D5 in what? Water. Technically in the bag, outside the body, it is an isotonic solution. Inside the body, your body metabolizes that dextrose and just leaves water. Water actually has a different osmolality than the saline that's in than the other water stuff that's in your body. So it actually turns into a hypotonic solution once the dextrose is metabolized. That's the only weird one. Okay, so D5W, isotonic in the bag, hypotonic in the body because the dextrose is metabolized. Because our body's going to use that sugar, and then all we're going to be left with is water. All right, let's talk a little bit about our different types of endocrine crises. We're going to start here with our hypothalamus. Your hypothalamus is the control center in your brain. It literally says, hey, I need you, you, and you to get out there and do your job. Okay? Think of it as your charge nurse. And they're not a nice one at that. Okay? So your hypothalamus is going to send signals to your pituitary, and it's going to tell the specific hormones to release and do the jobs that they're supposed to do. All right, a couple of hormones that we can see out of here. For instance, you have two different parts of your pituitary. Now, these aren't boobs. Thank you for not laughing. This is your pituitary gland, okay? You have an anterior pituitary and a posterior pituitary. Your anterior pituitary has a lot of hormones. You know, they're in the up front and center. They are ready to go, and they call the shots because they release a lot of different hormones. All right, one being your follicle stimulating hormone and your luteinizing hormone. What do we use that for?
Sex.
Reproduction, sex, all those things that we're not talking about today because we ain't got nothing to do with that. All right, it also releases prolactin. What is that for?
That milk.
Milk, lactation. We also don't need that, do we? And then it also releases growth hormone. What does that do?
Makes you grow.
Makes you grow. Y'all are so smart. I can't wait to tell Mr. McCarty how smart y'all are. Them suckers, we don't need nothing to do with those, okay? Follicle stimulating hormone, luteinizing hormone, prolactin, growth hormone, all well and good. However, I do not care about those. But our anterior pituitary also releases ACTH, which is our adrenocorticotropic hormone. And it also releases TSH. Adrenocorticotropic hormone and TSH. Those are two very important key hormones in our pituitary gland that we gotta have for this particular lecture today. The rest of it, I don't know who teaches y'all's OB stuff, but we ain't talking about that. All right? Now, your posterior pituitary, it only has two friends. One being oxytocin. I don't know why that couldn't be over yonder with all the other ones. What's oxytocin for?
Makes you feel good.
Uterine
Baby.
contraction, babies, all those things. We don't want none of that. We don't have nothing to do with none of that. All right, and then the last one, another key hormone related to your pituitary gland is your antidiuretic hormone. Okay? Now your antidiuretic hormone is the one that is responsible for SIADH and diabetes insipidus. So that's our first endocrine crisis that we're going to talk about. So you have your pituitary gland, you have an anterior and pituitary, and your three main hormones that you will see is your ACTH, your TSH, and your ADH. The first one we're going to talk about is ADH, or antidiuretic hormone. Antidiuretic hormone either tells your kidneys to hold on to water or let it go. Very beginning, remember we talked about hormonal imbalance and your body staying in fluid balance. Where your hypothalamus sends signals to your pituitary, and it tells your ADH to either hold on to water or let it go. It has to send a signal down to your kidneys, and it tells it what to do. It says, hey, we're losing too much water, shut off the valve. Or, hey, we need to get rid of some of this water, open the valve up. That's what your antidiuretic hormone is for. Now, your pituitary disorder that we're going to talk about is diabetes insipidus and SIADH. I put them here side by side. When you're studying these endocrine crises, study them side by side, okay? Because if you know for sure how one is, the other one is the opposite. It's an easy way to remember it, okay? So antidiuretic hormone, we're either going to hold on to fluid or we're going to let it go. So let's start with diabetes insipidus. Also, does anybody need a break? Are we good? If y'all need a break, will y'all tell me? Okay, because I'll just keep talking. Unless I have to pee. I got started on a water pill the other day, so I've been peeing a lot more than normal. And let me just tell you, I turned 41 and I feel like the world is ending because I got 3 blood pressure medicines the other day. Which my blood pressure was kind of out the roof, so I guess it was much
There with
needed.
you, lady. There with you.
Huh?
I said I'm there with you, lady.
Yeah. It was 211 over 117 the other day.
Ooh, good.
And I thought I was about to have a stroke. It was awful.
Well, make sure you take your medicine.
I do religiously now because I don't want to end up as a stroke patient at 41. That'd be terrible. All right, so let's talk about diabetes insipidus. Diabetes insipidus has either very, very, very little or no ADH at all. All right, if you get on your phone or your computers and you look up clip art for diabetes insipidus, you might see a dog like hiking a leg up on a fire hydrant because they are constantly peeing. They are constantly peeing. I think about that water valve that broke off yesterday and water's just shooting out everywhere and I couldn't get it to stop. Okay, this is my ADH was broken. I didn't have none. So for some reason, something is happening in this posterior pituitary and it is causing me not to get any ADH. So there's no antidiuretic hormone going to my kidneys. And if there is, it's only a teeny tiny little bit. So no antidiuretic hormone. So that's the case, I'm constantly peeing. When I say I'm constantly peeing, I'm talking about I'm having polyuria like up to 20 quarts a day. That's a lot. How many cups are in a quart? 4? No. 8?
8.
Somebody look that up. I don't even know. This is important. We need to see this. How many cups are in a quart?
Should be
How many? 8?
4.
4? Okay, what's 4 times 8? Because there's 8 ounces in a cup, right? What's 4 times 8?
32.
Okay, and there's 30 milliliters per ounce. So what's 32 times 30? 960. All right, divide that by 24. Oh, 40? Okay, that's about 40 milliliters urinary output an hour on average. Could be more. They can have a lot more than your 30 milliliters urinary output. These people are peeing constantly. All right, it's not like a normal person on a water pill. They are peeing a lot. And I mean a lot, a lot, a lot. But no, you don't have to know that math. I know I just threw you for a loop, didn't I? I'm sorry. But they are peeing a lot, like 20 quarts a day. You're peeing all that much. Yes.
Is that accompanied by really increased thirst?
Yes, that's where I was fixing to go. Also has polydipsia. They are extremely thirsty and they crave ice cold water. So my urinary output has drastically increased. All right, my thirst sensation has also drastically increased. So I have polyuria, polydipsia. If I'm doing all that peeing, what's happening to my fluid within my body?
It's diluted. Oh no, it's concentrated.
It's concentrated. I like it. It's concentrated. So I become dehydrated because all my fluid's going away. So if all my fluid is going away, it's all going in my urine, right?
Mhm.
So inside my body, I'm concentrated. But in my urine, I'm what? Diluted. So what happens to my urine-specific gravity?
It goes down.
It goes down, right? So I have a decrease in my urine-specific gravity. So polyuria, polydipsia, I'm dehydrated. I have a decrease in my urine-specific gravity. I'm really, really, really thirsty for ice cold water. It's the strangest thing. Why they crave ice cold water, I don't know. Because ice cold water tastes better than room temperature water, I guess. So how does this happen? How does my antidiuretic hormone get broken? How does that pituitary area get broken? Tumor, I like it. It's always a tumor.
It's always a two.
Always a tumor. Always a tumor. Most of anything that happens to the pituitary gland, most of these that are controlled by your pituitary gland, most oftentimes it could be a tumor. It could also be a head injury because where's your pituitary gland? In your noggin. Head injury could also cause that. It is extremely rare, meaning like 1 in 25,000 people get diabetes insipidus. So when I say I've never seen it, I have never seen it in 20 years. I asked some other instructors one time if they'd ever seen it. They're like, maybe once, maybe once. It's a lot more common with SIADH than it is diabetes insipidus. Another thing that's interesting about diabetes insipidus is if you're on the psychiatric medication lithium, lithium has a lot of different side effects, one being it can cause diabetes insipidus. So if you've got a psychotic patient on lithium, you gotta watch out for signs of diabetes insipidus. So how do I fix it? Ooh, I like it. If I ain't got none of this, then what I need? I need some of that, right? I ain't got none, I need some. So I can't just go, have my body make more antidiuretic hormone. Instead, I've got to give you the synthetic form of vasopressin. Or you can also use desmopressin acetate. So vasopressin or desmopressin acetate, pretty much the same thing. They are both synthetic forms of antidiuretic hormone. Now you've heard vasopressin before, right?
Mm-hmm.
Where have you heard it for? ICU patients to help with
Raising blood pressure.
blood pressure, right? To fix your blood pressure. How does it fix your blood pressure? It makes you hold on to fluid. Wow. Oh my gosh. Light bulbs. There it goes. I love it. Light bulb moments. So diabetes insipidus, I'm going to fix it by giving them some antidiuretic hormone. They need that synthetic antidiuretic hormone, so vasopressin or desmopressin acetate is what's going to help to fix that. As nurses, there's things that we need to do also. We call our nursing interventions, all of our nursing things, right? One being daily weights. Why is daily weights important? It is like the number one thing that you can do along with checking urinary output to get your fluid volume status. These also patients are also gonna need fluids. They are extremely thirsty, so I'm gonna give them as much ice cold water as they can possibly tolerate. Okay, so I'm gonna push fluids. I want to rehydrate them. I'm gonna push fluids. I'm also gonna do neurochecks because there's something wrong with my brain equals neurochecks, okay? Anytime there's something wrong with the brain, neurochecks. That's how it's gonna be. I'm also gonna make sure I'm checking my labs because I'm dehydrated. If I'm dehydrated, what might happen to my sodium level?
Goes up,
It might go up, and if that's the case, what might happen to my potassium level?
goes down.
It might go down. So do you think an EKG monitoring would be helpful?
Yeah, probably.
Most definitely, yeah. Do you know what the number one sign and symptom is of someone who has hyper or hyponatremia? Mm-hmm.
Loss of consciousness.
Change in their level of consciousness. So a change in their mental status or a change in their level of consciousness is usually the first sign and symptom that you will see in someone who has hyper or hyponatremia. So that level of consciousness is so important. We also got to figure out what the cause is. Find the cause and fix it. All right, that's gonna be the go-to for all of these endocrine crises. If we can figure out the cause and fix it, let's do so. Is it always fixable? No. We might just have to medicate it, okay? All right, let's look at the opposite. So I have diabetes insipidus. Now let's look at SIADH.
So instead of them peeing, it's gonna be not peeing.
They just gonna be not peeing. I like it. All right, they got too much ADH. Too much ADH, which means that valve is like closed off. All right, it reminds me of my pipe that busted. You know, first I had diabetes insipidus. Now I had SIADH because then it finally turned off. Took about 20 different tries to get it to turn off, but it turned off. So too much antidiuretic hormone is gonna do what to my urinary output, Sam? It's gonna decrease it. I'm gonna decrease that urinary output.
Decrease thirst too.
Decrease thirst too? Okay. What else is it gonna do?
Increase your kidney values.
Hmm?
Increase your kidney values.
Okay, most definitely can increase my kidney values. Yeah, it's gonna really mess up my labs. We're gonna talk about those in just a minute.
Increase
So
your
now it's
specific
gonna be-
gravity.
It's gonna increase my urine specific gravity. And instead of being dehydrated, what am I?
Diluted.
I'm overhydrated or diluted. So instead of being concentrated, I'm now diluted. So if I'm diluted, what's gonna happen to my sodium?
It's gonna go down.
It's gonna go down. Then what might happen to my potassium?
It's gonna go up.
It might go up.
You got cardiac issues.
And then I'm gonna have cardiac issues all over again. All right, SIADH is a lot more common than your diabetes insipidus. You actually will see it more common. What do you think can cause SIADH? Tumor. I love it. I'm telling y'all, tumor, okay? Tumor is almost the right answer for all of these. Tumor.
Well, that'd be great if you make sure that's on the test.
Yeah, I'm probably not gonna do that, but I might try.
Well,
It never hurts to ask.
yeah.
It's a great rule of thumb, never hurts to ask. Also, anything that's going to increase intracranial pressure in the brain can also cause you to shut off, or excuse me, also cause you to have an overproduction of antidiuretic hormone. So increased intracranial pressure, tumor, head injury. Also a very weird one, small cell lung cancer. Why is that?
Is it the renin angiotensin II mechanism?
Mm-hmm. Keep talking, Chuck.
RAS system?
The RAS system kind of goes in overdrive when you've got small cell lung cancer. Small cell lung cancer is actually responsible for a lot of brain issues, which is really strange. I don't know if that's the first place it mets to, or where the first place it mets to after it's in the lungs, but cause a lot of head injury issues. All right, so someone who has too much ADH means they're not peeing, they're overhydrated, so they have an overabundance of fluid. So as a nurse, what might I want to make sure that we're doing?
Weighing them.
weighing them, for sure, daily weights is a big deal. But these patients are also going to need to be on a fluid restriction. Now, how do I determine fluid restriction? You might know the formula to do fluid restriction? Okay, let's talk about it. Fluid restriction, I'm gonna have to get down here, is insensible losses, which is 500 milliliters, plus 24-hour urinary output equals how much fluid restriction they have for 24 hours. So let's do a little bit of math. This is probably the easiest math you're ever gonna do, I promise. Now, in order to determine fluid restriction, we do insensible losses plus how much urinary output they've had for a full 24 hours. That equals how much fluid they can have for the next 24 hours. Now, when you go to the hospital and you see patients, most oftentimes, if they're on a fluid restriction, the doctors put the order in for 1,500, 1,800 milliliter fluid restriction. Really depends on what their urinary output looks like, okay? Insensible losses, every time you talk, breathe, laugh, sweat, that is all things that we cannot account for, okay? Because nobody's gonna sit there with a measuring cup and measure every tear or every sweat drop that you have come off, or every bit of spit that comes out your mouth when you talk. So that's why it's called an insensible loss. Does that make sense? So everybody gets a credit for 500 milliliters. Well, what if I have SIADH so bad that I don't pee at all? What's my fluid restriction for the next day? 500. Because everybody gets 500 for insensible losses. Now say I pee 200 milliliters a day. What's my new fluid restriction?
700.
700, because 500 plus 200 equals 700. Very easy math. You might have one of those, Sam, I don't know yet.
It sounds like it.
It does,
Please,
doesn't it?
Give us like 4 or 5.
Give us like 4 or 5 of those, right? I know. I love math, so fluid restriction is a must. We're gonna calculate it based on their insensible losses, which everybody gets how much? 500, plus whatever their urinary output is for that first 24 hours. Another thing that we need to make sure that we're doing as a nurse is our patients with SIADH need to either be laying flat or no more than up by 15 degrees. 15 degrees is as high up as they need to go. Why do you think that is? I like it, pressure on the brain, okay. Think about, I'm putting pressure on the brain, what might be coming out? I already got too much what? Yeah, if I lay my patient down flat or up no more than 15 degrees, it actually helps to decrease the secretion of ADH. I know, right? Pretty cool, huh? So fluid restriction, they need to be laying down flat or no more than 15 degrees. Am I gonna do neurochecks? Yes, brain equals neurochecks, right? Now, if I gave patients with diabetes insipidus synthetic vasopressin, what kind of drug might I need to give someone with SIADH? Mm-hmm. What's an antagonist mean? What's antagonist mean? It's pulling you back to your 112, right? It's the opposite, right? It kind of fights the effects. It's the opposite. So we want to use like vasopressin receptor antagonist. These types of drugs are called Vapin drugs, or Vapten, V-A-P-T-E-N, Vapten drugs. I'm going to spell this drug out for you, okay? T-O-L-V-A-P-T-E-N, tolvaptan. We can also give declamycin. Both of those kind of shut off the ADH a little bit. Kind of helps to calm it down. So they're an antagonist, which means they're going to work against ADH. Over here, we didn't have any ADH, did we? So we had to give them the synthetic ADH. Over here, we got too much. So we gotta bring in something else to chill it down a little bit. So those antagonist drugs are gonna help to lower that ADH. These patients are also gonna have to get a lot of fluids. You ready for me?
No, it handled itself,
Oh, okay.
so we're good.
Fabulous.
Thank you.
Thank you, love. See you later. They're also gonna need fluids. Now, what type of fluids might be good for somebody with SIADH? They are overhydrated, swollen, drowning, fluid everywhere. What type of fluids might be good for these particular patients? Hypertonic solutions. Because in giving the hypertonic solutions, I'm going to pull the fluid from here into here. They might have to get some diuretics. That's up to the physician. That's not usually a common thing. Most oftentimes it's going to be pulling the fluid out of the cellular area and putting it in the vascular area and hopefully getting it out by use of the Vaptin drugs or the vasopressin antagonist drugs. Diuretics are not always a first-line use. They can potentially be used because we're using hypertonic solutions. Most oftentimes when you use hypertonic solutions, it's because you're pulling extra fluid in so that you can get it out in a hurry. The issues with hypertonic solutions is they have to be given very slowly because it can cause a rapid fluid shift. If I'm worried about fluid shifting, what am I going to be listening to? My lung sounds. I don't want to hear any crackles. If I hear crackles, we got some problems, right? So neuro checks, listening to lung sounds because I'm worried about the fluid shifting. Absolutely, positively with SIADH, they can get hypertonic solutions. Most oftentimes they're going to get 3% normal saline, but absolutely no IV fluids with water. No IV fluids with water. All right, that's it for your pituitary. That's diabetes insipidus and SIADH in a nutshell. Questions? Feel like you got a good grasp on it? Maybe so.
Yeah.
Maybe I need to go back and look at it again. Hmm?
Much better than I thought it was
Oh,
gonna be.
yay. Anybody need a break? Break, yep. Okay, let's take 5 real quick.